Ion channelopathies of the cardiac action potential, clinical implications and management. Cardiac ion channelopathies effect is almost equal to 0.2% of the global population and are responsible for is almost equal to 15% of sudden cardiac death, SCD, in patients less than 40 years. Mutations in Na, Ca superscript 2, and K channels alter phase 03 of the ventricular action potential, producing prolonged or abbreviated QT intervals, ST segment elevation, or polymorphic ventricular tachycardia. Diagnosis hinges on a combination of ECG criteria, e.g., QTc greater than or equal to 480 milliseconds, coved type ST elevation greater than or equal to 2 mm in V1-V3, and genotype-guided risk stratification using validated scoring systems. First-line therapy combines beta blockade, e.g., propranolol 1 mg per kilogram per day, with channel-specific agents, e.g., mexiletine 200400 mg TID, and, when indicated, implantable cardioverter defibrillator, ICD, placement per 2022 ESC guidelines. Key points. Note, long QT syndrome, LQTS, prevalence is almost equal to 1 in 2,000, 0.05% worldwide, with a 5-year SCD risk of is almost equal to 7% in untreated patients. Brugada syndrome, BRS, prevalence is almost equal to 5 per 10,000 in Southeast Asian males, with a 3-year SCD incidence of is almost equal to 12% in symptomatic carriers. A QTc greater than or equal to 480 milliseconds confers a twofold increase in ventricular arrhythmia risk. A QTc greater than or equal to 500 milliseconds raises the odds ratio to is almost equal to 4.5. The Schwartz score greater than or equal to 3.5 predicts LQTS with 96% sensitivity and 89% specificity. A score greater than or equal to 4.0 is diagnostic. Propranolol 1 mg per kilogram per day divided TID, max 240 mg per day, reduces LQTS-related events by 62%, HR 0.38, 95% CI 0.22 0.64. Mexiletine 200400 mg TID shortens QTc by an average of is almost equal to 30 milliseconds and lowers arrhythmic events by 45%. P equals 0.01. Quinidine 200 mg POTID, 600 mg per day, suppresses ventricular fibrillation in BRS with a 78% acute success rate, NNT equals 1.3. Isoproterenol infusion 210G/min for greater than or equal to 24H normalizes ST elevation in greater than or equal to 90% of BRS electrical storms. ICD implantation in high-risk channelopathy patients yields a 5-year appropriate shock rate of is almost equal to 15% and a mortality reduction of is almost equal to 55%, HR 0.45. Serum potassium 3.55.0 mol/L and magnesium 0.750.95 mol/L are target electrolytes. Hypokalemia less than 3.0 millimoles per liter increases TDP risk by is almost equal to 3-fold. Genetic testing identifies pathogenic variants in is almost equal to 75% of LQTS and is almost equal to 60% of BRS probands. Cascade screening reduces first-degree relative SCD by is almost equal to 30%. ESC 2022 guideline recommends beta blocker therapy for all symptomatic LQTS, Class 1, Level A, and quinidine for BRS with recurrent VT/VF, Class IIA, Level B. Overview and epidemiology. Cardiac ion channelopathies are inherited or acquired disorders that disrupt the normal flow of Na, Ca superscript 2, or K ions across the myocardial cell membrane, thereby altering the ventricular action potential. The International Classification of Diseases, 10th revision, ICD-10, codes include I-45.81, long QT syndrome, I-45.82, Brugada syndrome, and I-45.89, other specified cardiac conduction disorders. Global prevalence estimates place LQTS at is almost equal to 0.05%, 1 in 2,000, and BRS it is almost equal to 0.05%, 5 per 10,000, in high-risk Asian cohorts, with a markedly higher male predominance. Male-female is almost equal to 8:1 for BRS. In the United States, an analysis of 1.2 million ECGs identified 1,340 individuals with QTc greater than or equal to 480 milliseconds, translating to a prevalence of is almost equal to 0.11%, 95% CI 0.10 0.12%. Age distribution shows a bimodal peak for LQTS, 1025 years, is almost equal to 45% of cases, and 5570 years, is almost equal to 30%. BRS manifests predominantly in the third to fourth decade. Median age is almost equal to 34 years. Racial disparities are evident. BRS prevalence is 12-fold higher in Southeast Asian males compared with Caucasian males, reflecting a relative risk, RR, of is almost equal to 12.0, p less than 0.001. Pathophysiology. The ventricular action potential comprises 5 phases, 0-4. Phase 0 is mediated by rapid Na influx via NAV 1.5, SCN5A, channels. Phase 1 involves transient outward K current, ETO. Phase 2 is the plateau sustained by L-type Ca superscript 2 channels, CAV 1.2, CACNA 1C, balanced by delayed rectifier K currents, IKR encoded by KCNH2, IKs encoded by KCNQ1. Phase 3 reflects repolarization via IKR, IKs, and inward rectifier K, IK1, encoded by KCNJ2. Phase 4 is the resting membrane potential maintained by Na/KAT passe. In LQTS, loss of function mutations in KCNQ1, LQT1, 35% of cases, or KCNH2, LQT2, 30%, diminish IKR/IKs, prolonging phase 3 and extending the QT interval. Gain of function mutations in SCN5A, LQT3, 1015%, increase late Na current, INAL, prolonging phase 2-3. The net effect is a QTc prolongation greater than or equal to 480 milliseconds, predisposing to early after depolarizations, EADs, that trigger torsades de points, TDP. Clinical presentation. LQTS classically presents with syncope, is almost equal to 45% of first presentations, seizures, is almost equal to 12%, or sudden cardiac arrest, is almost equal to 8%. In pediatric cohorts, 30% of events occur during exercise, particularly swimming in LQT1 carriers. BRS typically manifests as nocturnal syncope, is almost equal to 40%, or aborted SCD, is almost equal to 30%. Fever-induced syncope accounts for is almost equal to 20% of BRS presentations, especially in Asian males. CPVT presents with exertional palpitations, is almost equal to 70%, and syncope, is almost equal to 25%. Atypical presentations include asymptomatic QTc prolongation discovered incidentally on routine ECG, is almost equal to 15% of LQTS cases, and concealed BRS with normal baseline ECG but positive drug challenge, is almost equal to 25% of carriers. Elderly patients, greater than 70Y, may present with dizziness rather than syncope. Diabetics with autonomic neuropathy may lack prodromal symptoms, is almost equal to 10% of LQTS events. Diagnosis. Stepwise algorithm 1. Initial ECG, measure QTc using Bizet's formula, identify type 1 Brugada pattern, coved ST elevation greater than or equal to 2 mm in V1-V3. 2. Repeat ECG after greater than or equal to 30 minutes or after drug challenge, Agmelin 1 mg per kilogram 4/5 minutes, if baseline is non-diagnostic. 3. Laboratory workup, serum electrolytes, K 3.55.0 mol/L, Mg superscript 2 0.750.95 mol/L, renal function, creatinine less than or equal to 1.2 mg per deciliter, liver enzymes, ALT less than or equal to 40 U/L. Hypokalemia less than 3.0 millimoles per liter has a sensitivity of is almost equal to 78% for TDP precipitating events. 4. Genetic testing, next-generation sequencing panel covering greater than or equal to 30 genes, e.g., KCNQ1, KCNH2, SCN5A, RYR2. Pathogenic variant detection rate is almost equal to 75% in LQTS and is almost equal to 60% in BRSE5. Risk stratification, apply Schwartz score, LQTS, and Brugada clinical score. Diagnostic criteria key points, LQTS, QTC greater than or equal to 480 milliseconds plus Schwartz score greater than or equal to 3.5. Or QTC greater than or equal to 500 milliseconds regardless of score. BRS, spontaneous type 1 ECG pattern or drug-induced type 1 pattern plus at least one clinical criterion, syncope, VT/VF, family history. Schwartz score, 3 points for QTC greater than or equal to 480 milliseconds, 2 points for T-wave alternans, 1 point for syncope, 1 point for congenital deafness, 0.5 points for family history. Wells score, for differential diagnosis of syncope not directly applicable but helps exclude PE, score greater than or equal to 4. Management and treatment. Key points, monitoring, continuous telemetry, QTC measurement every 30 minutes, and serum electrolytes Q4H, stabilization. For TDP, administer 4 magnesium sulfate 2g over 5 minutes. Repeat Q5 minutes up to 6g total if refractory. Isoproterenol, initiate infusion at 2. References. 1. Liu H. et al. Neuromechanisms underlying the coughing reflex. Neuroscience Bulletin. 2023, 39, 12-18-23-1839. PMID, 37606821. https://pubmed.ncbi.nlm.nih.gov/3760681. DOI 10.1264-S12264-023-01104Y2. Dixon R.E. et al. Mechanisms and physiological implications of cooperative gating of clustered ion channels. Physiological Reviews. 2022, 102, 31159-1210. PMID, 349274454, https://pubmed.ncbi.nlm.nih.gov/349274454. DOI 10.1152/physrev.00022.2021. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.